So what is the case you are presenting?
Hypertension and pregnancy.
Okay, hypertension complicating pregnancy.
28-year-old Mrs. X, wife of Mr. Y, resident of Ernakulam, who is a 10th class by education, homemaker by occupation, with an obstetric score of Gravida 2, Para 1, Live 1, with an LMP of 8/6/2022 and EDC of 15/3/2023. Now currently completed 34 weeks of gestation. She is a known case of gestational hypertension on labetalol 100 mg BD for past 2 weeks. Now she is admitted in view of high BP recordings of 160-100 mm mercury. There was no any history of headache or blurring of vision or epigastric pain or vomiting.
So what is the criteria of hypertension in pregnancy?
BP recording of more than or equal to 140/90 mg mercury. 2 readings taken 4 to 6 hours apart in a previously normotensive patient more than 20 weeks of gestation.
So 4 criteria should be. So after 20 weeks, previously normotensive patient. 2 readings of 140/90 or 4 hours apart. After 20 weeks in a previously normotensive patient. That is hypertension. What is proteinuria?
Proteinuria, the cutoff is urine protein creatinine ratio more than or equal to 0.3. Urine proteinuria more than or equal to 300 milligram per deciliter in a 24 hours urine collection, or dipstick more than or equal to 2+.
So normally there is a excretion of urine proteinuria 300 milligram in 24 hours, but this 300 milligram present in one hour, or if it is more than 300 milligram, then we have to take it as proteinuria. How do you detect proteinuria? By protein creatinine ratio, which is equivalent to 24 hours collection. Okay.
Trimester history. First trimester, it was a spontaneous conception. UPT done 10 days after missing periods was found to be positive. Regular ANC done thereafter. First trimester antenatal investigations was done and was all within normal limits. Folic acid was started. Dating scan was done at 8 weeks of gestation and the growth were corresponding. There was no history of any fever, thrush, hyperemesis or radiation exposure or teratogenic drug intake. There was no high BP recording seen in the first trimester. Second trimester, iron and calcium was started. Quickening felt at 5th month of gestation. 2 doses of injection TT taken 1 month apart. Oral glucose tolerance test was done at 24 weeks of gestation and it was normal according to the IA-DPSG criteria. Anomaly scan was done at 20 weeks of gestation and there was no gross anomalies and Dopplers were normal. She was normotensive and euglycemic. There was no any history of headache or blurring of vision or epigastric pain. Third
what are you trying to rule out by saying there is no history of vomiting, epigastric
It's an impending sign of preeclampsia.
Severe preeclampsia. Or impending eclampsia.
Impending eclampsia. Third trimester, iron and calcium continued, appreciated good fetal movements. Growth scan was done at 28 weeks of gestation, showed corresponding growth with adequate Leica and normal Dopplers. At 32 weeks of gestation, patient presented to the OPD for routine antenatal checkup. At that time, it showed a high BP recording of 150-100 mm mercury, which was recorded to 4 hours apart, 2 readings. At that time, PIH profile was sent, which was within normal limits.
So, what do you call it?
It's a gestational hypertension.
What is the incidence of preeclampsia in gestational hypertension?
It's 25 to 30%.
So you have to need close monitoring patient. Whether a domiciliary, what is antihypertensive you start?
First line of management should be oral labetalol 100 mg BD.
Do you think that this 150-100 will respond to 100 mg?
No, every BD? Third day we have to check the BP. If it's high, we have to make it increase the dose or change the second line of antihypertensive.
Is there a place of domiciliary management because there is no proteinuria, the BP is controlled with your antihypertensive drug?
Yes, ma'am. She can be managed on OPD basis. Domiciliary management should be followed. She should be given...
Provided the BP is only 140/100, you have to admit the patient. Because 150/100 at any time, the diastolic BP can go above 110, which is a case of diagnostic criteria severe preeclampsia. So you have to admit if the BP is 140/90, you can send the patient home. So what is the role of domiciliary? What all things you tell to a patient? What awareness you give to the patient?
The patient should be given awareness regarding the impending eclampsia signs like any headache or blurring of vision or vomiting, epigastric pain. She should report to the hospital. The relatives should be explained about the complications. She should stay close to the hospital. If possible, home monitoring of BP can be done. If it's more than 160/110, she can report to the hospital immediately.
2 times she must take the BP. Weekly she is ready to come to the OP. And what about the activities?
No restricted activity, ma'am.
What about salt?
No salt restriction.
But salt according to the taste and no extra salt.
No extra
salt food should be avoided. That also you have to stress the patient.
Stress the patient.
So even you have to give the phone number of the hospital or the doctor to consult the doctor that she is having, because what are any other immediately the patient has to come to the hospital.
When she started to if there is a severe headache or vomiting, any
Or
impending,
else
she should
even
report.
pain abdomen
abdomen, any
because
history of
there is high
abruption.
chance of
Abruption.
So they have to bring the patient very immediately to the hospital. So even the number of the doctor also has to be given to the patient relatives to report immediately, to tell them that they are on the way to the hospital, so that we can arrange everything ready for the patient, necessary for the patient. So domiciliary management, so BP is under control. Even if the proteinuria is 0.3, we can have a domiciliary. When do you admit the patient? She is not having any complications. What is preeclampsia?
Preeclampsia is with proteinuria, same more than or severe signs of
the definition of proteinuria is
urine protein creatinine ratio more than or equal to 0.3.
high blood pressure with
more than or equal to
or a multi-organ failure, because 20% of health syndrome can occur even without proteinuria. So now the definition is either hypertension with the proteinuria or a multi-organ failure. This is a preeclampsia. So severe preeclampsia means the blood pressure is more than 160/110 with evidence of any multi-organ failure. So that is severe. So this is a case of non-severe preeclampsia. That is why domiciliary treatment was possible. So how often you call the patient for checkup?
She should come for weekly management, weekly checkup.
Suppose the next week the BP is 150/100, but ILFT is normal, RFT is normal, the protein creatinine ratio is only mildly elevated. You will admit the patient or send the patient home?
No, we can send her.
The patient. So when the in the hospital, how often you check the blood pressure? It is a non-severe.
Every 6th hourly.
Every 4th hour you have to check the blood pressure. And then
urine protein creatinine ratio, platelets, LFT, RFT should be sent
twice in a week. When the patient come for antenatal checkup also, you need not repeat the protein creatinine ratio. You know that there is protein creatinine ratio, so you check the creatinine,
platelet and LFTs
and the liver function test to know whether she is going for any complications. Okay, related to that. So now she is completed 37 weeks. So 34 to 37 weeks, either you can admit the patient or domiciliary management. If the patient stay very near the hospital and the blood pressure is only 140/90, not 150/100 onwards, you need to admit the patient. Okay. Now she reached that. Suppose how long you continue the pregnancy to?
Non-severe preeclampsia till 37 weeks.
Why not after 37 weeks?
There is no benefit.
There is a high chance of developing severe preeclampsia and added morbidity and mortality to the mother and the fetus. That is the reason why we need to admit the patient by 37 weeks. How do you take steps to deliver the woman?
First, when she is admitted, after ensuring the maternal and the fetal well-being, a pelvic assessment and a Bishop score should be, a cervix favorability should be assessed. If it's an uneffaced cervix, we can try.
So pelvis, adequate pelvis,
and then Bishop scoring should be done.
And then how do you induce? The patient is not in labor. How do you induce labor?
If it's an uneffaced cervix, if Bishop score is not favorable, mechanical induction should be done with Foley's. The Foley's bulb should be inflated up to 60 ml with a normal saline and a traction to be given. And pharmacological method with oral prostaglandins. Prostaglandin E1 orally 50 microgram 2 hourly.
After 6 or 12 hours of Foley's. Sometimes it may expel or may not expel, but we can keep for 24 hours. Meanwhile, you can also start PGE1, oral or vaginal. Oral, how often you repeat?
Every 2 hours.
Vaginal, how often?
Every 4 hours.
Suppose you want to give oxytocin after the prostaglandin. What is the interval between prostaglandin and oxytocin?
6 to 4 hours.
4 hours should be the, suppose she is in labor, she started labor, Foley's is expelled, and you have given PGE1. So the contractions are not sufficient. Good enough. What do you mean by good uterine contraction?
3 to 4 contractions lasting for 40 to 45 seconds in a period of 10 minutes.
10 minutes. So if the contractions are not adequate, you can start oxytocin also. But the interval between prostaglandin and oxytocin should be minimum 4 hours. And when the patient starts labor pain, What else we do to accelerate the labor pain?
Oxytocin can be given, on artificial rupture of membranes.
What is the advantage of doing ARM, early ARM for this particular patient?
In case of hypertension, uteroplacental insufficiency will be there, so high chances of meconium stain liquor will be there. So,
In case of preeclampsia, because there is a uteroplacental insufficiency and also high chance of fetal growth restriction, so early ARM is advisable to know whether the liquor is meconium stained. In that case, patient needed emergent cesarean section, thick meconium especially. So the labor is progressing. How often you check the blood pressure?
Every hourly the BP should be monitored.
Okay, the blood pressure is more than 161 and the patient is also complaining headache.
Acute management of hypertension should be done. The first line of drug of choice is labetalol, that is 20 milligram IV over a period of 2 minutes. Then recheck the BP after 10 minutes. Then give 40 milligram IV. Then recheck the BP after 20 minutes. Give 80 milligrams.
10 minutes. Every 10 minutes we have to check the BP. And
20, 40, 80, maximum of 300 milligram.
If 3 doses by 3 doses patient is not, the blood pressure is not controlled, we can change it to another drug.
To second.
What is the other drug we give?
Nifedipine can be given. 20 to 30 milligram. 20 milligram BD.
20 minutes apart.
20 minutes apart.
3 doses. 60 milligram is the maximum dose. Or else you can give IV hydrolysin also, which is not available. But the dose of IV hydrolysin is 5 milligram IV. You boost up, maximum is 30 milligram. That is the dose of IV hydrolysin. You can even give IV labetalol also in that infusion pump also. You can give 1 gram per minute. This is how we give acute hypertension. Otherwise, acute hypertension can lead to cerebral hemorrhage. And if the cerebral hemorrhage is massive enough, even death of the patient can occur. Okay, that is the reason we have to control the blood pressure. And if the patient is complains headache, she is going to develop eclampsia. To prevent that,
seizure prophylaxis with magnesium sulfate should be given.
So the same dose, like that of the eclampsia. 4 gram?
4 gram in 100 ml NL, 4 gram IV in 100 ml NS over a period of 20 minutes, followed by a maintenance dose of 1 gram per hour over a period of 24 hours. Latest K4 recommendation is with the 4 gram IV, you have to give 4 gram IM also.
So that a recurrence of convulsions will not occur if at all is a case of eclampsia. Usually conventional magnesium sulfate is very effective method of conventional prophylaxis. What are the patient is in labor, what are the indications of emergency cesarean section?
If the BP is uncontrolled, if she is showing any impending signs, if there is any non-progression of labor or any fetal decelerations,
and also
bleeding.
So because there is a high chance of abruption. So the labor is progressing. Okay, so a bottle should be there in the labor room to monitor the patient. To know the fetal heart rate.
Continuous CTG monitoring should be kept. Maternal vitals should be monitored. Pulse oximeter, BP cuff should be connected to the patient.
Okay. She is progressed well and fully dilated. How do you conduct the delivery?
In the second stage of labor, in a hypertensive patient, Valsalva maneuver should be avoided. If the condition is all satisfying, an instrumental delivery is opted. If it's +3 station is completely dilated and completely rotated, outlet forceps can be applied. If it's a higher station, we can go with vacuum.
What is active management in the third stage of labor?
Uterotonics, injection oxytocin, 5 units IV followed by 10 units of IM, controlled contraction and uterine massage.
Okay. And what is the normal blood loss at delivery?
250 to 500 ml.
So even this 500 ml may not a patient with preeclampsia may not tolerate because what is the reason?
Because of the extravascular
blood volume expansion is less. Blood volume expansion. So after delivery, everything is normal. Actually, how long you monitor the patient? High dependency area.
She should be kept in the high dependency unit for 48 to minimum of 48 to 72 hours.
Why?
Because the chances of eclampsia is high in the postpartum period.
There is again a chance of postpartum eclampsia. That is the reason why she has to be kept in the
high
dependency area. And then will you continue the patient blood pressure is still high? It is controlled but still high. What is the drug of choice?
Nifedipine is preferred in the postnatal period.
Postpartum period. So how long you continue? When do you discharge the patient?
We can discharge the patient on the 5th day or 6th day of the postnatal period. After 1 week, she can...
sometimes atypical eclampsia can occur by 7th day also. So afterwards, the BP is controlled, you can discharge the patient. And the patient has to recheck the BP?
After 1 week, she can check in her local hospital. After 2 weeks, she should come to us for a BP monitoring. And if the BP
is controlled?
If the BP is controlled, she can... Normal BP
we can stop. Or else you continue till?
6 weeks of
6
pregnancy.
weeks, and by 6 weeks the BP still again
We have to refer to her nephrologist or
To
a
rule out
physician.
what?
Any a chronic hypertension or any renal disease,
Okay.
underlying renal
What are
disease.
the maternal complications and fetal complications of severe preeclampsia?
In maternal complications, first is cerebral hemorrhage, eclampsia, blindness, papillary edema, retinal detachment, pulmonary edema, HELP syndrome, acute renal failure, DIC,
Acute renal injury.
acute renal injury,
Kidney or renal failure.
DIC, abruption,
What is MH?
microangiopathic hemolytic anemia.
And abruption
Abruption
placenta. And the fetal complications
Fetal
are
complications, fetal growth restrictions, sometimes intrauterine death or any perinatal mortality.
fetal growth restriction, intrauterine death.
Intrauterine
And then
hypoxia.
preterm, why? Because we induce labor for induced labor for the sake of the mother and fetus. So if it is severe preeclampsia, for your idea I am telling, if it is severe preeclampsia, if it is less than 26 weeks to terminate the pregnancy, because by continuing the pregnancy the mortality of the mother is high because of the complications. If severe preeclampsia, again after 34 weeks also we terminate the pregnancy, deliver the woman, because by waiting we are again the life of the mother is at risk. But between 28 and 34 weeks there is a period of conservative management provided it is a tertiary care center with a skilled obstetrician, with a neonatologist, appropriate neonatal care and fetal medicine expertise. In that case we can continue the pregnancy provided mother is stable, fetus is stable. In that case we can continue the pregnancy with antihypertensives and convulsion prophylaxis. Also it gives steroid for lung maturity. And then the maximum, the studies prove that the maximum we can wait is 7 to 14 days, but with a morbidity of 5%. At any time patient go for any deterioration like fetal count, sudden fall in platelet, high proteinuria, massive proteinuria, or patient showing symptoms of epigastric pain and then also headache. In that case the cervix is unfavorable, definitely go for cesarean section. Preterm, again we can induce labor provided mother and fetus stable, but preterm there is a high chance of failure of progression labor. Only 30% may succeed in delivery. Other patients may go for cesarean section. So this is about hypertension complication. Now we have discussed about gestational hypertension. You can allow the pregnancy to continue till 38 weeks. If it is hypertension not controlling with the drugs, on and off the blood pressure is even after with the drug, it is uncontrolled blood pressure, even without proteinuria also we need to terminate by 36 weeks. So this is about the hypertension complicating pregnancy.